Hello everyone. We have started the preparation of medicine subject and we have started the hematology portion. We have discussed the first three topics, that is iron deficiency anemia, megaloblastic anemia and hereditary spherocytosis. Now we will discuss the most important topic, that is aplastic anemia. We are having a scenario that there is a 20 years old male who is presented with 6 months history of ill health, low grade fever and generalized aches and pain. He is also giving history of epistaxis, bleeding from gums. 20 years old male is presented with 6 months history of ill health, low grade fever and generalized aches and pains. He is also giving history of epistaxis, bleeding from gums off and on. On examination, he is anemic, temperature is 101 degree Fahrenheit, plus is 100 per minute with unremarkable systemic examination. HB 8 gram, TLC 3000 and platelets 8000. Another scenario is that we are having a patient of 20 years boy, high grade fever, generalized body aches and pains, episodes of epistaxis, easy bruising and bleeding gums. On examination, he is toxic, pale with bruises purpurae over legs, his HB is 8, TLC 1200 and platelet is 26,000. So what is the definition of plastic anemia? We are having normocytic anemia with low reticulocyte count, results most commonly from suppression of stem cells function by activated T cells. Aplastic anemia is defined as peripheral blood pancytopenia, that is low RBC, WBC, and platelets with aplasia, that is inability to produce blood cells of the bone marrow. The causes of aplastic anemia is idiopathic, infectious, that is cytomegalovirus, inherited, and varicella zoster. The clinical features are anemia, neutropenia, thrombocytopenia, and splenomegaly is absent in hereditary spherocytosis. The investigation in not in hereditary spherocytosis, in the aplastic anemia. Okay, the investigation options are diagnosis by clinical presentation, then marrow biopsy, which is most accurate, bone marrow biopsy revealing hypocellularity and space occupied by fat, and then CBC, that is pancytopenia. The treatment options for aplastic anemia is supportive, that is anemia. For anemia, blood transfusions are done. For infection, antibiotics is given, and for bleeding, platelets are given. The definitive treatment in young patients in less than 30 years, allogenic bone marrow transplantation, which is curative. If no HLA identical siblings, then immunosuppressive therapy or androgen steroid to stimulate hemophilia. Then the complications of aplastic anemia are severe infection, bleeding, hemochromatosis, and iron overload. The prognosis is 80% with bone marrow transplant. Severe aplastic anemia managed with supportive therapy alone is poor. Is more than 50% patients die within the year. So we have discussed the aplastic anemia, its scenario, that high grade fever, body aches and epistaxis, bruising, bleeding gums, toxic pale, bruises purpura over the legs, and 8 gram DL-HB. So what is the definition of plastic anemia? Then what are the causes? The history questions ask about exposure to drugs, that is chemical and radiation, and ask about viral infection, for example hepatitis. Then we discuss the causes, the clinical features, and the investigations, which are diagnosis by clinical presentation, then the bone marrow biopsy is done, and the CBC is done. The treatment options are supportive and definitive, then the complications, which are severe infection, hemochromatosis, bleeding, and iron overload, and then we discuss the prognosis. Now coming towards the idiopathic thrombocytopenic purpura. We are having a scenario that there is a 78-year-old unmarried lady presented with epistaxis, menorrhagia, gum bleeding while bruising teeth for the last 2 months. She looks healthy but is pale. On examination, has few purpuric spots on thighs. BP is 115 by 65 mm of Hg. No lymphadenopathy or splenomegaly is present. HB is 8 gram per dl. TLC 7500 and pol is 70%, lymph 30%. Platelets count 12,000 and there is no immediate cells seen on the peripheral smell examination. Another scenario is that there is a 25 years old female diagnosed 2 years ago with idiopathic thrombocytopenic purpura, has presented to OPD with bleeding gums and fatigue on trunk and legs. She has been using steroids in these 2 years. Okay, with idiopathic thrombocytopenic purpura, has presented to OPD with bleeding gums and fatigue on trunk and legs. She has been using steroids in these 2 years but getting no improvement. Her FPC done shows the HB 9 gram per dl, TLC 10,000, platelets 15,000, Newton to power 9. So the diagnosis, investigation, management, complications, and the side effects of corticosteroid. So the definition of idiopathic thrombocytopenic purpura is that it is a disease caused by IgG antibodies against glycoprotein 2b or 3A receptors. It is an isolated thrombocytopenia, hematocrit, and WBC count are normal. The differential diagnosis of idiopathic thrombocytopenic purpura are myelodysplastic syndrome, infection that is HIV and hepatitis C, SLE, HUS, DIC, and drug-induced thrombocytopenia. The investigation options that are done are CBC, which is the hallmark of ITP, is thrombocytopenia. Other cell lines are normal, platelets slightly enlarged, bone marrow show normal or increased number of megakaryocytes, bleeding time prolonged. The reduction of platelet autoantibodies is not essential for confirmation of the diagnosis. Diagnosis depend on exclusion of all other causes of excessive destruction of the platelets. Smear is microspherocytes. Coombs test is positive. PT and APH is normal. APTT is normal. Bleeding time is prolonged, and bone marrow biopsy increased number of megakaryocytes are there. The treatment options for ITP are first line therapy is no bleeding, platelet count greater than 30,000, then no treatment. If mild bleeding is there and platelet count is less than 30,000, then glucocorticoids are given. If severe bleeding, that is CNS or GI, and count is less than 10,000, then prednisolone, glucocorticoids plus intravenous immunoglobulins are given. Intravenous anti-RBD in RH positive patients. Splenectomy is done, which is the most definite treatment for ITP, and consider if patient has more than 2 relapses. Intravenous immunoglobulins are given. It can raise the platelet count by blocking antibodies receptors for 1 to 2 days. Platelet transfusion is done for persistent or potentially life-threatening bleeding. Danazol is given for patient not responding to prednisolone, and splenectomy may be given. Immunosuppressive therapy is given in refractory cases. Immunosuppressive drugs such as vincristine and azathioprine and cyclophosphamide are given. The complications of ITP are intracranial bleed, vitamin K deficiency, liver disease, bleeding from the GIT, hematolosis, and non-healing wounds. The side effects of corticosteroids are glaucoma, high BP, mood swings, psychological effects, confusion, delirium, hirsutism, Cushing syndrome, and osteoporosis. So we have discussed the topic idiopathic thrombocytopenic purpura, the scenario for it. Then we are having a patient who is having 2 years ago idiopathic thrombocytopenic purpura and has presented to the OPD with bleeding gums and fatigue on trunk and legs. He is using the steroids in these 2 years and there is no improvement. So what is the definition of ITP? Then differential diagnosis, the investigation options which are CBC and bone marrow biopsy, detection of the platelet antibodies, smear, Coombs test, PT and APTT, bleeding time, and bone marrow biopsy. Then we discuss the treatment options, which are the first line therapy, then the splenectomy, intravenous immunoglobulins, platelet transfusions, danazol, immunosuppressive therapy, the complications and side effects of the corticosteroid. Now coming towards the next topic, that is hemophilia. We are having a scenario that there is a 17-year-old boy who was brought to the emergency with pain and swelling of the right knee while playing football. He gave history of similar episodes in the past. On examination, he is febrile and his knee is hot and tender to touch. His investigations reveal FBC and platelets normal, prothrombin time is normal, and APTT is prolonged. Another scenario is that there is a 16-year-old boy history of fall, painful swelling on the left knee joint after a fall, had similar episodes in the past. Young brother had bleed from a long time after circumcision. Investigations show normal full blood count, normal platelet count, APTT is prolonged. So what is the diagnosis, investigation, the mode of inheritance of the disease, and the management? So the definition of hemophilia is that it is the most common congenital coagulation factor deficiency and the cause is reduction in amount or activity of factor 8. It is X-linked hemophilia B due to factor 9 deficiency. The clinical features of hemophilia are spontaneous hemorrhage, hematolosis, that is bleeding into joints after trauma. The investigation options for hemophilia are bleeding time is normal, PT is normal, APTT is raised, factor T, that is C, is low, one world blood factor is normal. Mode of inheritance is X-linked recessive, is inheritance pattern. The management options are factor 8 concentrate by intravenous infusion, recombinant factor 8, synthetic vasopressin rises factor 8, and C in mild cases. Mild cases desmopressin is used, severe cases recombinant factor 8 is used, and in hemophilia B, recombinant factor 9 is used. Counseling is done for the patient, that is introduce, then educate patient about disease and reassure him. Tell him about factors which can precipitate bleeding. Patient should avoid contact sports, trauma, predisposing activities, etc. Advise them to approach treating a physical in emergency if bleeding get initiated, and later on and then say thanks. So we have discussed the last topic, that is hemophilia. We discussed the scenario, then the definition option, then the clinical features and investigation options, the mode of inheritance, the management, and the counseling. So in this video, we have discussed the 4 topics. That is, okay, we have discussed the aplastic anemia, the idiopathic thrombocytopenic purpura, the hemophilia, and leukemias. The first 4 topics are discussed in video 1. The second 4 topics are discussed in the video 2, and the rest of the topics we will discuss in the video part 3. Thanks for watching.